So hello everyone, myself Dr. Soumya Banerjee. So today we are here regarding how to manage or how to approach a patient with ascites, right? So let's try to understand from the examination. Okay. So in the examination, you are obviously able to understand there is a abdominal fullness, which is eventually 90% sensitive in that case. Also, this kind of patient will show you like increased abdominal girth. There is a weight loss. The poodle sign would be seen easily. Also, apart from that, the shifting dullness and the fluid thrill is pretty much important in such cases. Okay, your peritoneal tapping is very much important while treating such patient. So obviously, we would like to discuss regarding the peritoneal tapping here as well. So you have to monitor such patient in a regular interval, because like the how much amount of the ascites has been developed till now, that is pretty much important. So your abdominal girth and the weight is typically measured regularly in such patients. Okay. Also, always try to look for the jugular venous distension. There is a hepatic murmur and the signs of congestive heart failure. Also, the signs of the pulmonary edema, skin changes, asterixis, anasarca, and the Virchow's nodes are very much important to acknowledge by the clinical examination. Okay. So always uh, we have the grading and the staging. Okay. So for the grading, we have the mild one, like the mild ascites, where you can able to get poodle sign positive. Also you can able to uh, get the detection of the ascites through the USG in that case as well. In case of moderate ascites, obviously there is a shifting dullness or there is a no thrill that has been there. In case of tense abdominal ascites, there is a fluid thrill, and the patient will eventually show some respiratory difficulty in some cases. But in case of staging, we do need to understand like it's a basically plus one, which is basically obtained from a careful examination. Your plus two, that is easily detectable through the examination, and your plus three, which is obvious, but there is a no tense ascites in such cases, but your plus 4 is the tense ascites, and obviously in that cases patient eventually comes to you with a history of respiratory difficulty as well. So obviously first of all you do need to confirm that, then always try to assess the cause of the ascites, and then you can try to assess what are the complication that has been there. So regarding this, obviously the blood test has been there, like the CBC, complete urinary examination, LFT, clotting factors are supposed to be done. Regarding the imaging studies, obviously you have the chest abdominal film, which will eventually show some elevation of the diaphragm. Obviously, there is some non-specific signs would be there, like the Helmer sign, obliteration of the hepatic angle. There is a dog ear, Mickey Mouse sign, which would be present in such cases. But obviously, medial displacement of the cecum, ascending colon, and the lateral displacement of the uh, um, preperitoneal line has been pretty much sensitive. So for the USG, you have to go for the site for the paracentesis. It's a your usual way to go for the paracentesis is always USG guided. Okay, so in the USG you can able to detect 100 ml of fluid minimum, and obviously in case of uncomplicated ascites it is eventually shows some homogeneous freely mobile anechoic collection in the peritoneal cavity. Okay, and obviously there is a deep acoustic enhancement that is also being shown. Also there is a massive ascites like the small bowel loops. There is a polycyclic and